All right. Well, thank you everybody for joining us. We are going to be very punctual and start right at the top of the hour. Thank everybody for joining us for this, what's going to be a very interesting webinar by Dr. Monkley and Dr. Miller on implementing evidence-based protocols. Just a couple of things to mention as we get started. The first is that we are broadcasting this simultaneously. So as Amanda says, we are simulcasting this both on Facebook and on Zoom. So if you have questions on Facebook, there's instructions on the left side. If you have questions that you want to submit via Zoom, the instructions are a little bit there on the right. And it's relatively self-explanatory. I think many of us have become Zoom and perhaps even Facebook Live experts as we've muddled through the pandemic and certainly our winter weather. So next, we want to let everybody know that the session is being recorded so that you will have the opportunity to download, watch this multiple times. And knowing Dr. Miller and Dr. Monkley, and Rick Farron as well, you are definitely going to want to watch this over and over again. So it's a good thing that it's not actually on cassette tape, because we would probably break the tape as you see on the screen, and we'd probably all struggle to find a pencil if we needed to rewind the tape back into the cassette. Those of us old people understand that relationship, and you younger folks probably don't understand what that means. Amanda, we can go to the next slide there, ma'am, if you don't mind. This program is being brought to you by the Academy for International Mobile Healthcare and Gold Guys Roll. Thanks, John, I appreciate that. Aim High, and you see the members there. Aim High is essentially an organization made up of high performance, high value EMS systems. The systems that you see listed on the screen are some of the most written about, some of the most researched. They produce some of the most research and just do an incredible job of trying to advance our profession forward. And we are very appreciative of all these members and our president, Chip Decker from the Richmond Ambulance Authority, for allowing us to do these educational programs and the entire board. So Amanda, we can go to the next slide. Yes, and we can see your mouse. You should do like some fun mouse. So Trinidad in the Caribbean. So thank you for joining us from internationally. We are bringing the international into the Academy of International Mobile Healthcare Innovation. So integration. Thank you guys very much for being here. I'm going to turn the floor immediately over. You got the bios for Dr. Monkley and Dr. Miller in the promotion. So we want to make sure that we can get right into those folks. So we're going to turn the floor over to Dr. Monkley and Rick Farron to talk to us about how things work in the Great White North when you're developing protocols.
Thank you, Matt, and thank you, Amanda, and good day, everybody. Yes, our presentation today is about using evidence and outcome data to create a clinical and an operational dispatch protocol. Next, Rick. I'm Dr. Doug Monkley. I've been an emergency physician and an EMS physician for many years, a bit of a long timer. I now have a co-director and co-medical director at Niagara EMS. Rick Farron, I worked with as an advanced paramedic, but he is now Deputy Chief System Performance at Niagara EMS. I call him my data guru. He's actually also a PhD student who will be using some of the data you're going to see in the future here shortly as part of that work. So as background, the Niagara region has a population of about 500,000. We're in the province of Ontario, Canada. Ontario has a population of about 15 million. As you can see on the map, we're surrounded by a lot of blue. That would be Lake Erie in the south, Lake Ontario in the north, and then the Niagara River separates the Niagara region from Upper New York State. To the west of our region, it's very rural and agricultural. So the take home here is we need to be self-sufficient, because there's nobody coming to our rescue if we deplete our resources. There's no real practical mutual aid arrangement. We run 33 ambulances during the day, the majority of which are advanced life support. We now have emergency communication nurses in the dispatch center, handling the lower acuity and omega type calls. We run 4 mobile integrated health teams, a care team which looks at the lower acuity patients in-house in the patient's home, the falls intervention team, which includes an occupational therapist. We have one mental health and addiction team, which includes a mental health professional. We have a fairly modest community paramedic program. We have a small palliative care program, and we provide paramedic staffing for one opioid consumption and treatment site. Importantly, we are a priority dispatch accredited center. We have been so since 2005, but we are one of only 2 in our whole province. Next, Rick. So in the decade between 2007 and 2016, we experienced an increase of call volumes, the highest in our province. We were running 6 to 7.5% increase in call volume per year. And of course, our funding comes from a single payer system, that being our provincial and municipal governments. And our funding was going up at 2.2 to 2.5% per year. The blue line is one of our consultants' view that we would double our call volume in 10 years. So you don't have to be an MBA to figure out that this was not going to be sustainable, particularly in a single payer system. So we had to look at some sort of transformation. So our senior management team decided to rethink how we provide service. We had the support of our municipal government to get the funding to do so. And so we looked at other places internationally that had had a similar problem where they were unable to keep up with demand. And in fact, one of the areas that we found a lot of commonality was in the Welsh ambulance service in Wales in the UK. So through 2018, 2019, we did a process, a collaborative process with our stakeholders in the hospitals and the universities nearby. So we had to design and implement and integrate a whole new system. And in fact, our system today looks very different than it did in 2017. We were able to revisit some policies to kind of get some low-hanging fruit right off the top. We stopped going to wellness checks for the police. We integrated the emergency communication nurse system and the integrated health teams that but we also developed alternative transportation. We're actually very close right now to signing a taxi contract for those people who transportation is their only barrier. And we have other destination options now, like walk-in clinics, urgent care centers, and even transport to a family doctor. But to knit this all together, we needed a clinical response plan and that would, look at the evidence, look at our own data, and inform our decision making. So what's some of the evidence we looked at? Lights and sirens use, obviously there is a concern about its safety to the providers and to the public. I don't have to tell most of you that there's lots of studies to show that there is very little impact on time, but a significant danger to the public and to our providers. So it's a risk-reward scenario. Again, we know that there are certain conditions that we deal with in EMS that are very much time dependent: cardiac arrest, respiratory arrest, stroke, penetrating trauma, and a few more, but the majority have very little evidence that a better response plan gets you a better outcome. So from our perspective, we had to get it right. Our risk was not under triaging. Our bigger risk was depleting all our resources by sending everything hot and eventually not being able to send an ambulance to a 911 caller who was critically ill or injured. Rick, you want to take it?
Absolutely. So one of the things that Dr. Monkley just mentioned in terms of stakes, we often think of risk in our system as, the risk of under triage, and that is a significant risk and something we have to be aware of. But the other risk that often gets forgotten is the risk of not having enough resources to send. And so in Ontario, we've certainly faced not only resource challenges, but we've also faced challenges with offload delays at hospitals. And I don't know how many areas for folks listening experience similar, but when you have ambulances being depleted due to the calls they're doing, as well as, waiting at hospital for an extended amount of time, this affects your resource availability. And when everything is being sent out hot indiscriminately, the chances are great that you run into a situation like this on the right, which is, at least my right, which is a nearby municipality. And this is just one example that I was able to quickly find where that exact thing happens, where, when the true need comes in, you have nothing left to send. So that needs to be incorporated into system design as well.
So as part of the system transformation, we did a very extensive literature search, and I think Rick's going to allude to some of that later, but these are the kind of articles we were looking for. And the first one is actually a fairly recent article, and it used ESO data from the United States, 6 million calls from 1,200 agencies, 85.8% were sent red lights and sirens. But of that group, only 6.9% of those calls resulted in a potentially life-saving intervention. When you look through the methods, the definition of a potentially life-saving intervention was fairly broad. Even giving glucose was a lifesaver. So again, we had to look from our perspective at the risk of reward of sending everything red lights and sirens. Another one, this is a study out of Calgary. Calgary is a city of 1.5 million in Alberta, Canada, and they use an MPDS system. And they looked at, of all their Echo and Delta calls, their priority 1 and 2 calls, those greater than 8 minutes and those less than 8 minutes, they actually found no difference in all-cause mortality. No difference at all, but they did find a small beneficial effect in those patients who did survive to become an inpatient. In the discussion, however, they said these patients are so complex, it's hard to tease out as to whether an improved response time was actually responsible for their small increase in survival.
And so if I can add, in addition to using a use of lights and sirens, the safety and effectiveness of that, as well as time and what impact that might have on patient outcomes, we wanted to understand some of the changes that we were making. We're not the first to start applying some clinical evidence and some rationale to how they're creating those priorities. Certainly BC has done some of this work, and this is another example of a study that, something that we would have looked at. We wanted to know what was the impact of response plan changes on patient outcome. So now you start linking clinical data to that. You start linking hospital data and see what happened to patients. And this is a retrospective study that was done out of BC, Talon et al. And they're looking specifically at 24-hour mortality. And basically, in this system, the changes that they made, they were able to show that it was no more risk, and in some cases, less risk than what they had been doing previously. And the other thing that we wanted to understand as we did all of this work, what does the patient expect? And we did literature searches for that. Didn't find a lot, some passing references. And so we wanted to understand, what is the patient's attitude? Do they always expect what we think they expect in terms of, I call 911, I expect the lights and sirens ambulance to be there, virtually immediately? Or is their review a little more tempered? And so we did our own research because there was not a lot of that. So as Dr. Monkley said, we started by doing research on looking at the outcome of response times on what sorts of conditions was there a benefit. We did a scoping review. We looked at well over 300 articles and found 84 where there was some benefit shown of response plans, of response time on outcome. It's no surprise, I'm sure, to most listening that 70% of those related to out-of-hospital cardiac arrest. We know an awful lot about out-of-hospital cardiac arrest in time. And then there was some other smaller numbers of studies that looked at trauma, specifically penetrating and head injuries, and other subsets in there, such as CVA, certain arrhythmias, and one of the ones that actually did link that we found was torsion of the testicle. And we actually incorporated that knowledge into the response plan because it was one we actually found evidence as a surgical emergency of time on outcome. The other one that we did ourselves was a qualitative research with regards to public perception. So we interviewed 2,500 citizens, or had them do surveys. And we gave them two scenarios. One scenario was the acute scenario, the person having a heart attack, a stroke, what do you expect? And then we gave them another scenario, which was, a sprained ankle, some minor flu-like symptoms or something less serious. And we asked them what they expect. And we certainly weren't surprised in the results for the urgent scenario. People expect pretty much what you'd think. But in terms of the non-urgent scenario, there was a majority of patients who were quite willing to have the situation assessed by phone or receive some guidance by phone, linked to other services, or maybe even just giving information and advice. And that was surprising to us that there was that great acceptance even before we had started down a road of educating about what we were able to offer. These are the clients that our chief often says they call 911 to find out whether or not they should call 911. Yeah, they're looking for that kind of guidance. And as a system, we can probably provide that.
So we have put together a number of response plans over the years, and we've kind of evolved to a point where we are now using a lot of data and evidence. Initially, we used our own Canadian Triage and Acuity scale. This is a 5-point scale, with 1 being the most critical and 5 being the least. It is used coast to coast in Canada, both by paramedics and by emergency departments to triage the clinical acuity of their patients. It does line up nicely with the MPDS priorities, and we used that in the beginning. By 2008, we had our own data where we could look at what paramedics had actually done and actually what paramedics had found when we compared the priority that they went out on to what they found when they got there based on a CTAS level. By 2019, we now had the mobile integrated health teams functioning, the ECN teams functioning, and we were able to look at their effectiveness measures. A good point about the ECNs and the MIH, in this system where we're not going as urgently to every single 911 call, these teams do more than just avoid an ambulance transport to the hospital. They provide a very significant secondary triage. In the case of the ECNs, it's the ears listening to them for 15 or 20 minutes en route and on the phone. And for the MIH teams, it's putting eyes on the patient. And so, yes, they do avoid a lot of ambulance transports, but just as importantly, they pick up the ones that were under triaged in the initial triage in the dispatch center. But what's really revolutionized things and is very exciting to talk about is the population-based patient data that we have been able to acquire from our province about a little over a year ago. So this is called Integration Decision Support Data, our IDS data. It comes from the Ontario Hospital Association. Hospitals in the province of Ontario, their medical records department have to code every patient that comes through the doors and kind of follow their patient journey with certain coding. It's part of their funding system. So of course it's done very well because they want to get their right funding for the kind of patients that they're seeing in hospital. But this is a very rich new data ecosystem for us. It's very detailed and gives quite detailed outcome data on almost all of our 911 callers, and it integrates not just hospital data, but some primary care, community health, and public health data as well. And Rick was actually the one who was able to get us the access and the link to this, and it very much informed our most recent iteration of our dispatching protocols.
Yeah, thank you, Dr. Monkley. And in terms of what that gives us, now that our data is being fed into that system, including the MPDS determinant, we're able to run queries against that and look determinant by determinant and find out what happened within the hospital system. And this is just a small example of some of the things, and you'll see a more detailed example in a few minutes, but we are able to look at what was, by determinant, what was the mortality, what sorts of diagnostics and procedures were done in ED, how many patients ended up having to return to ED within 3 days, as well as who was admitted, how long they stayed, and how many of those folks ended up actually staying in ICU and for how long.
So this response plan working group is a subgroup of the dispatch review committee. We get together only when a change in our dispatch response plan is in order. The 2 medical directors are there, our senior team is there, our middle managers, and all the other people who work hard and make me look good. But of course, we also bring on board the paramedics, the dispatchers, and the mobile teams to give more information as we make our plans. It is a collaborative process. We usually want to get there by consensus, but I will say that the medical directors ultimately have I guess, a veto power and can upgrade a response if need be. That happens, though, surprisingly infrequently, because we are usually able to work through the data and the evidence to get a consensus.
So I mean, everybody here probably has response plans at their agency. The important point here is to look at what our 5 priority system looks like when we use lights and sirens in our system, and we do give paramedics discretion on priority 2s based on what they hear. They get the dispatch information on their mobile data terminal, and based on what they're seeing on the traffic conditions, what they're seeing in clinical conditions, they do have that option. But the priority 1s are the ones that we do insist on lights and sirens, and the target there is 8. So that would include most of your echoes, of course, in the priority 1s, some deltas as well. In terms of going through the response plan with all of this data that Dr. Monkley has talked about, we go determinant by determinant. So it's an iterative process, and decide which response plan needs to be applied to that. And of course, there's over 200 variations by the time you look at allied agencies and notifications and other things that we want dispatch to know based on that determinant. So this is an example after we've gone through and done a comparison of what our found acuity looks like compared to our priority, what procedures paramedics are performing, what the MIH and ECN's success rates are. Once we look at all that, the final step is now to actually look at the outcome data for each determinant one by one. I've included an example here of the 6 Charlie 1, which is abnormal breathing. You know, there is no, the patient's alert, they're not changing color, right? For those people who don't maybe use MPDS. And I've actually thrown in a 6 Echo 1 as a comparison there, which 6 Echo 1 is ineffective breathing. So the highest priority or the highest acuity determinant. And you can see looking at the red circles, and this is kind of the whole, you know, printout that we would get, but looking at EMS records, I can see how many times we've got a record of that particular determinant. So the percentages and the numbers all make sense. And in this case, for a 6 Charlie 1, I've used this as an example because we had this as a priority 3 in our system. And when you look at the 1-day mortality, it was interesting that the percentage for 1-day mortality was actually more significant than what we were seeing with the 6 echoes. The next is the linked visits, which is just tells us how many actually linked ED records there are. And so in the case of a 6 Charlie 1, 277 linked records. And if you look at the next red circle there, you can see that the 3-day revisit rate was comparable or higher than a 6 Echo 1. You can also see in the next one at the bottom, the next red circle, the number that resulted in admission. So 128 out of 277 resulted in an admission. That rate is about the same as the Echo, same with total length of stay. And the numbers who required stay in an ICU, that can be a step down or an ICU unit, those numbers were also comparable or higher, as well as the average length of stay. So we looked at this and realized that whereas we had made decisions before about this particular determinant with our the information we had at hand, when you add this new layer of outcome data, it warranted a more significant response. As we went through the process, and again, it was an iterative process, you can see that this is the new priority. We increased this 6 Charlie 1 and the 6 Charlie 1 Alpha to a priority 2, which now gives a shorter time target that allows paramedics to use lights and sirens if they elect to, and that's a small percentage of times, and it goes to the closest transporting unit. So as we went through that iterative process, we also saw similar trends in the 6 Delta 1, 6 Delta 1 being the not alert patient. And we increased some of those deltas into the priority 1 category, as well as changing the actual responding resource from what would have been the closest transport unit to the closest unit. So now we send the closest thing, as we do with a cardiac arrest, for those 6 Delta 1s, using a similar approach and seeing similar things that we were seeing in outcome data related to those determinants.
Yeah, I thought I'd address the issue of lights and sirens uses. In the rest of Ontario, around 80 to 85% of 911 calls go out as lights and sirens. You can see that in 2018, 2019, in the second column, we were sending 42% out lights and sirens, and are now sending in the neighborhood of 10.3% lights and sirens. Match means that when they arrived on scene, they found a CTAS 1 patient, which clinically was the highest priority. And a mismatch means that they were not sent lights and sirens and found the highest priority patient. So when they elected to use lights and sirens based on notes on their dispatch or travel or what have you, we had a mismatch where that is to say only 0.9% of the most critically ill patients were not sent an ambulance that was running lights and sirens. So very little difference, probably statistically insignificant. So we're comfortable with that. I might add, just from a paramedic's perspective, they have accepted this idea that they don't need to go lights and sirens on all calls. And it's because we have, for the last 30 years actually, integrated research and evidence into what we do and how we teach our paramedics. Our paramedics have also been involved in a lot of multi-sensor trials. So there is a kind of a culture that if the evidence says we can do it in Niagara EMS, the paramedics seem to accept that.
So the next step is to validate some of this and to take the approach that the BC took and do some retrospective analysis. Here you can see, as Dr. Monkley said, the paramedics found acuity. Does that translate into any changes in patient outcome. And so this approach needs to be validated. We need to do a population-based evaluation of those outcomes. Did the methodology change anything about outcome? Did we improve? Did we increase risk anywhere? And use that information not only to inform future iterations of our plan and continue to refine it, but also make sure that we're sharing these learnings as we go with the EMS community in formats such as this.
Back to you, Matt.
All right. Thank you guys very much. Now we're going to turn the floor over to Dr. Miller, who's got some great information about how we do things here in the MedStar system. So Dr. Miller, take her away.
All right, good afternoon, everybody. Matt, confirming mic check and slides are up.
Things look fantabulous, sir. Thank you.
All right, so that was an incredible presentation from our Niagara colleagues. So I want to follow their portion of how they're applying the evidence base and using data-driven decisions on the response plans and the destinations out of it, and highlight what our MedStar and the Office of Medical Directors work has been on our recent protocol development and credentialing cycles that we've been in the midst of for about the last year and a half now. So I don't have any disclosures for this. I will say a couple of proprietary resources out there that I utilize. I'm purely a consumer and have no conflict of interest in any of those. And so you'll see those later in the presentation as well. So about us at MedStar, we are a self-operated public utility model EMS system. We cover 15 cities in the Tarrant County area of Texas with a suburban and an urban environment with 100 million residents over a very north-south distributed 438 square mile area with about 150,000 requests for service per year. Traditionally, we have been an all ALS medic EMT service. We've just taken a foray into a few BLS units in a pilot project that's ongoing right now as we continue to transform our response and service models as well, similar to Niagara. And then we have 15 municipal first responder organizations as well. All of our medical responders, including our FROs, operate under a unified protocol, credentialing, and quality assurance process through the Systems Office of the Medical Director. And so I'm very happy to work with our team here. We are lucky to have a very robust Office of the Medical Director, and so we have our 2 medical directors in a current vacancy, our chief of staff, and then the bulk of our office's work occurs at our 2 division or teams level. We have our clinical quality team, which does our quality assurance and quality improvement activities, and then our clinical practice team, which is responsible for our training, education, and all of our credentialing activities as well. And so with our team here, we keep incredibly busy in all the Office of the Medical Director activities. So I want to move first into how we have taken a spin on the evidence-based protocol development and talk about how at a national level the push is going, and then how we've implemented that locally here at MedStar. From a national perspective, there's been a large push for some time now. This occurred back in 2001 when NHTSA made a call for evidence-based protocols for EMS. And then that was followed up in 2006 with the Institute of Medicine making recommendations for evidence-based models for pre-hospital care guidelines. And then there's been significant work over that decade in developing kind of the groundwork for evidence-based protocol development. And so now we've seen a significant acceleration of evidence-based guidelines from a national level. We've seen several be produced, and then the National Model EMS Clinical Guidelines came out in 2013. NEMSP has also made a national strategy on how to develop, implement, and evaluate pre-hospital evidence-based guidelines, and then the Pre-Hospital Guidelines Consortium came out in 2015. Other things have occurred, such as EMS Compass, and then some revisions in the National Model EMS Clinical Guidelines, and then EMS Compass was subsequently rolled into NEM Squad in 2017. Since then, over the last few years, more guidelines have come out, and then as recently as just last week in Pre-Hospital Emergency Care PEC, we had some additional work on looking at evidence-based guideline development and implementation, where they did a modified Delphi analysis on critical areas of need for additional guideline work, and then a systematic review of where we are as far as these guidelines development go. Additionally, the National EMS Assessment came out in 2020, and they looked at how is each state implementing their EMS patient care protocols. And as you can see across the US and its territories, there's significant variation here. So about 34% of our states are under some kind of mandatory protocol with varying abilities to develop, modify, revise, or petition for specific local level changes. Additionally, about 29% have some state model protocols that then are used to shape the local ones. And then about 21% are in the local protocol type strategy. And this includes us here in Texas. Obviously, we are known to be fiercely independent. And I guess we operate under a mantra of don't tread on my protocols. And so, so we are certainly firmly in that area. And then a few are under regional protocol variation as well. So moving now here into how we've operated under the Office of the Medical Director here at MedStar. We developed our current format of protocols in 2017, and then we've been operating under 2-year revision credentialing cycles since then. We did a minor revision in 2019, and then we came up due for a new revision in 2021, which has been the work that I'm going to highlight here. So this is very much the elephant taking a bite at one at a time. And so planning was very key for as we've gone through these protocol changes here. And so we found that it was incredibly beneficial to use some project management principles on all these things. And so this is an example of one of those online project management things such as Monday, where you can essentially lay out your timetable for your implementation. And we found that this was incredibly helpful in scheduling everything out. That way we weren't having to push this over just one quarter or a few cycles. And really it maintained bandwidth for all the other office activities, but able to implement a robust protocol evaluation and change process. And so these are free on some services and platforms. And so you can certainly use these, and I'll highlight a few more uses of this in a second. So where do you start? Where do you find your material for all these changes? Maybe you were a service who has a badly needed protocol set that needs some updates, or maybe you are one of those that is on the forefront of updating them every year or every 2 years. And so where do we go for our material for all this stuff? And so obviously the natural place to start with is just your guidelines and your position statements. And so this is our first crack at things, was taking all the AHA, PHTLS, TCCC, NRP, and then your NAMSP and other societal guidelines, and incorporating any of the updates that we felt were necessary in those purposes. And so 2020 was obviously a landmark year, and a lot of them put out all the protocols. And so they came in pretty hot and heavy. And so that was a large bulk of some of our updates along the way. But obviously that doesn't capture all the changes that we need to know. So if you're just following AHA type guidelines, you're probably not catching the wide net of all the protocol changes you may want to do. Another incredible resource is the EMS evidence-based medicine collections. And so this is your national model EMS clinical guidelines. They are updated every year to 2 years and cover virtually all your main protocols that you can expect. And if you start with nothing else, this is going to be where you can at least have a trusted source of information to update your protocols. You know, anywhere from a jellyfish toxicity all the way up into a cardiac arrest is covered during these guidelines, and has some great evidence-based stuff. Additionally, our friends in Canada, Dalhousie University has the pre-hospital evidence-based practice website. Here they incorporate a large amount of evidence and break them out into specific categories. And so this can certainly highlight the areas of our EMS practice and show you some level of clinical evidence and give you a accept, reject, or somewhere in the middle type rating on a lot of your practices. And so this is another great area of resources as well. And then, as mentioned earlier, the Pre-Hospital Guidelines Consortium also has developing a repository in that way that can also help you along the way. So I, like many of us now, have a very difficult time trying to follow the constant stream of literature that's coming out. It really does feel like this tidal wave. This picture was out of Science Magazine and was talking about the COVID-19 papers and how basically it's about to swamp all of our boats there. And so the best way I've found is, how do we filter this information that I can follow along as the literature comes out? And so these have been some of the resources that our team has found beneficial on how to follow the literature along the way and not have to rely on the 6 months right before a protocol revision. And so I divide these out into kind of 4 categories here. For kind of streams of your literature information, I found that Read by QXMD has been particularly beneficial. This is a service where they will drop into your inbox specific journals that you are following. And so you can get a highlight of the topics there, and it will vary them as they come out per month. And so you can just get into your inbox, at least a synopsis of the major things there. Journal Feed will also take a specific article, highlight that, give you a quick synopsis, and that's also an email or a podcast format, as well as a website. FOAMed is obviously a double-edged sword, but is a great resource for keeping up to date on a lot of the major landmark protocols, and certainly some of the evidence-based gurus in emergency medicine and other formats provide a lot of great perspective in this way. Certainly, we can get a little off track on some FOAMed because it is an expert opinion, but again, it's a great resource. Since there is a ton of FOAMed, using something as an RSS collaborator such as Feedly can help you keep track of those as well. As far as podcasts go, I have a 45-minute drive every day, so I am an avid consumer of podcast resources. And so I've highlighted a few here, and I think these are some of the best that cover evidence-based literature that's critical to EMS. And so these are such things as NEMSP's PEC podcast covering the PEC journal, the Recess Room, which covers our European colleagues' journals, the Scandinavian Trauma, Resuscitation, and Emergency Medicine Journal. And then our friend, Dr. Jeff Jarvis and Mike Kess, EMS Lighthouse podcast is also a phenomenal resource for evaluating evidence-based medicine. And then finally, kind of as a fallback for me particularly, is Med Twitter. If you curate your follower list appropriately, this is my last resource to catch and make sure I'm not missing an important paper coming out. And it's kind of one of the best resources to catch some of the cutting edge topics. And again, the idea is to catch some of the cutting edge topics, put them into a, tuck them away in a folder, and then evaluate them at a later date, whether this is a little too bleeding edge or something else that we want to do. And so this is a mechanism that we've found appropriate to catch some of those lower level changes that are important to inform our practice, but are not going to bubble up to the level of a evidence-based guideline or a systematic review type of things. Then, as many of our EMS agencies have, is that you're going to have some protocol questions that come up that require a little bit of a deeper dive. And this is where our PICO or our population intervention comparisons of need and outcome of interest format comes into play. And we indeed did have to do a few of these. Here in Texas, we don't have a lot of cold water submersions, but we had a couple operational questions come up from our search and rescue teams as how long is too long for a withholding or resuscitation on some of these victims. And so this was some of the topics that we came out and evaluated in a targeted fashion there. A very large part of our protocol updates was driven by quality assurance and quality improvement driven changes. And so these are things that we have seen in our QA/QI process that have been issues, whether that be, areas of care that are just often forgotten. Examples are our traumatic cardiac arrest. We were seeing a deprioritization of some of the critical interventions that are needed, such as needle decompression and hemorrhage control in place of epi. And so we wanted to target some of those areas so we could be a little bit more effective in some of our resuscitations. Additionally, our online medical control calls have also informed a few of the changes. Some of the things that we were seeing constantly being called to medical direction and with a very high rate of granting clearance to do those things. We just incorporated some of those into our protocols to allow our providers and clinicians to use good judgment and continually update our protocols in that way. And then the final piece of our puzzle, as far as we were uploading our protocols, is feedback from the field. And we thought this was vastly important. It gave our field a sense of ownership of the protocols that they were allowing to give a direction as far as our system, and bringing what their concerns and what their observations were directly at the field and patient level up to these things. And so we made a feedback request to the field on this way as well. So what happened is we basically took all these things and then kind of put them into a pile, and rather than a large paper pile stuck on someone's desk, we used the project management system and made a master change list. And so this is some of the power of the project management systems out there, is that you can organize them into a much more orderly fashion. And so this is a list of all of our changes from a period being missed all the way up to some significant protocol additions. And we could lay them out and separate them out into medical, trauma, OB and whatnot, and then track their changes, attach papers that were important to evaluate them. As far as then, we did an internal review utilizing the pyramid and hierarchy of evidence, particularly those that we had kind of pulled along the way, and did kind of a final quality of evidence to say, is this something that's very low and is a little too bleeding edge, or is this something where we've seen to the level that is bubbled up that we feel this is comfortable in our system to consider for implementation. Another large part of our internal assessment of protocol changes was using our QA/QI data to inform. And so this is an example of a data report that we pulled as far as nitroglycerin. And so we had seen some research, particularly to our colleagues in the South, Montgomery County, as well as some critical care chems services, where they were using bolus dose nitro for acute pulmonary edema and had some good outcomes as far as improvement in respiratory status and vital signs. And so we took a look at that in our system to see how we were doing at baseline with just using sublingual nitro and CPAP. And when we delved into our systems information, we were actually doing fairly well with just CPAP and sublingual nitro. And so we made the decision off of this to not pursue the complicating factor of adding an IV modality of nitro and all the training associated with that, because based on what we were evaluating our literature, we were seeing that we were doing okay as is in status quo. And so after we'd done our initial internal review and had evaluated all of our possible changes, we rolled that up and brought it to a protocol committee. And we found that this was a really awesome thing for us to have feedback from all of our stakeholders. And so we included all of our operational representatives, including our field training officers, supervisors, leadership, including logistics into this was key as we were evaluating pricing and carrying of different items and how do we distribute that out. Had all of our OMD components as well. And then finally, we also included our first responder organizations representatives, as these some of our changes would affect minimum carry or what they would be doing at their point of contact. And so evaluating all these things as a team allowed us to take this as a true system approach and evaluate and have some cohesiveness from a system level there. So this is an example of how we were evaluating each of these different components. And so for ketorolac, we were considering adding this for pain management. Certainly from an evidence-based standpoint, it's been shown to be safe, it's effective. We, from an operational perspective, felt that we could carry this item as pennies on the dollar as far as pricing. From a medical oversight perspective, we felt we could evaluate this from a QA, QI, and education and training standpoint. So the verdict was yes on something such as that. We had a field suggestion and had multiple online medical calls for consideration of TXA and GI bleed for hemorrhagic shock. However, there was a recent trial that had come out that had not supported that practice. And so from an evidence-based standpoint, that was not supported. However, it would have been otherwise operationally feasible with us carrying TXA and medically oversight appropriate as far as training and oversight. So the final verdict on that was a no. Another area was withholding resuscitation for greater than 73 years old, unwitnessed and non-shockable rhythms. So this was, again, an evidence-based practice. We'd actually published an abstract in a national meeting on this using our own data. However, then discussing locally as far as how our EMS providers would feel about implementing such a practice and, looking at a family and explaining these type of things. Our systems felt that this time was probably not tenable there. And again, our medical oversight perspective was appropriate. So the final verdict on that was a no. With droperidol coming back in, we were very happy to consider that as possibly a change from haloperidol. Again, evidence-based good on that. But when we looked at it in our logistics, folks informed us fairly quickly on this, that this was a 10 to 11 times increase in cost. And so adding $200 to $2,000 to our medication budget for a fairly similar medication was not exactly something that we were super happy about doing. And then as far as RSI, we don't constantly get that as a suggestion from our field. Obviously, the evidence base is a little plus or minus on this. We felt it was operationally feasible to add the medication, but then from a medical and oversight perspective, we felt that we had some key components in place that we still wanted to do, including first pass success and implementation of video laryngoscopy prior to adding this as a consideration in our protocols. So what we did there is basically a TBD, or to be done in the future, and added a roadmap to RSI for our field to understand what are the steps that we take for that. Now the hard part was basically taking all those recommendations, actually putting them into a protocol creation. So these are a couple examples here of some of our protocols that we implemented based on some of the evidence bases, as well as our quality assurance processes, such as our crashing medical protocol, which was modeled after some of our colleagues for Pittsburgh, as well as our own MedStar flair to that. And then our traumatic cardiac arrest, as noted, where we are prioritizing the interventions that are most critical in a traumatic cardiac arrest and de-emphasizing ACLS. So after that, we did our protocol rollout, as many of us have struggled with the COVID-19 pandemic has made in-person teaching extraordinarily difficult. And so we had to fall back onto our system-wide learning management platform and video-based content for a lot of it. And so we did an overview of our protocols and then went into a little bit more of a high yield. This is where we had an opportunity to delve into and translate some of that evidence-based practice that was behind the protocols and put that into a digestible format for our providers out there in the field to understand the why behind the changes. And then we were able to do some live quarterly CE during some of the lightens up of the pandemic. And then we did some skills review videos to cover the new procedures. And then finally, we're entering right now into our credentialing cycle of protocol testing and skills verification, where we're going throughout our system to credential our providers on our new protocols. Now, as we implement our protocols in the next month is on our horizon, is some discussions of whether the periodic 2-year updates is really what we want to continue to go with, or is this going to be more of a living document? We found that some of these 2-year updates limit our ability to continually do our CQI processes and implement some of these new updates, such as a post-ROS checklist or something of that sort in the protocol cycles. And so considering some changes along the way with appropriate training and making this more of a living document. We've also considered, rather than the kind of the all-call, cattle call of the 2-year skills verification, is moving into a longitudinal fashion with our CE cycles, where we can cover a little bit more in depth and provide a little bit more hands-on opportunity and mentorship on some of the high acuity, low opportunity skills, such as cricothyrotomy and intubation and whatnot, and give it a little bit more focus and a very quick skills verification in the 2-year cycle. So finally, with all of our protocols, and all this requires credentialing and education and training. And so this is the national perspective again for you. And so the National EMS Scope of Practice model gives a very cohesive graphic, which I love, which is talking about how we have our education from our initial and continuing education components. The National Registry certifies all of our members as competent after they pass the state's license at the, but then at the local level, there's a large diversity and variety of providers' clinical and operational abilities, as well as scope of practices. And so the credentialing by the medical direction level has been a very significant and serious thing for us here. And so NEMSP has come out with position papers on these type of things and highlighted the significant areas, the cognitive, affective, psychomotor skills. And then a large focus at MedStar has been on the critical thinking of the provision of clinical care in those applications, those other three things. And so as we found, it's not just your high acuity patient, it's on the entire spectrum of all of your acuity patients, from the low lift assist all the way up till that nasty airway. They also did provide some guidance as far as the re-verification of and re-credentialing, and providing some guidance that it be every 3 years is the best. So here's a layout of kind of our credentialing process. We have a 14 to 15 day clinical NEOP classroom portion, which includes some didactics as well as cadaver lab and equipment day, and then a simulation. We have our protocol and skills verification, then a field training component. And then finally, the roll up of all that is a simulation mock medical director interview with our clinical practice team, and then followed by a tabletop medical credentialing interview with either myself or our fellows or Dr. Vitolani. Big component of our things are that it is a competency-based training, that time does not necessarily equal competency in this way. And so we certainly have an operational consideration that we want to get our providers out in a timely fashion and maintain some operational neutrality in that way. However, a number of shifts, number of patient contacts and whatnot is not necessarily going to verify competency of each provider. And so having an evaluation process that verifies competency is something we felt key. So this is our other strong tenet is case-based training and evaluation. And so rather than having a lot of didactics, particularly in our field training process, has been that we know that we're not going to have specific contacts for each level of patient. And so applying a case-based training and evaluation, including in our train the trainer, has been a large focus of our push as an office on this. We've also had some complexities of the credentialing FRO agencies as well. So we have a very large diversity of FROs, from a volunteer, very small funding and small workforce component at some of ours, all the way up to career services with a large number of providers. And so while we've had a great classroom portion for our MedStar, bringing that NEOP content to the station for each of those new trainees has been a large focus for us, and a push. And then training the trainers for our FRO, FTOs, and then working on how do we gain clinical exposure for them as well. And then the final part is what we're working through is, as we incorporate this evidence-based exposure, has been incorporating the why into our training and letting our providers understand and translate from our appraisal of the evidence, their appraisal of their protocols, and how do they apply the evidence to their practice and understand why each of the things are there, particularly where we are contrasting from what their initial training was and telling them to do something potentially even in direct opposite of their initial training, and understanding the why and getting the buy-in behind that so that they will be able to follow through with the protocols once they're out of the field. So that's kind of our take on how we've done things at MedStar. I'm again very grateful for the opportunity to talk, and I'll pass it back to Matt.
All right. Thank you very much, Dr. Miller. We have about 2.5 minutes. We're going to try and answer a couple of the questions that came in on the Q&A link. First question, when you talked, Rick, about, and Dr. Monkley, the 79% of the calls don't need life-saving interventions, is there a better way with a lower acuity intervention that should be utilized, or should there be a protocol change?
The way I look at it is what we have to do is pick out those ones that are going to have potentially life-saving interventions. So I think it's, again, looking at the evidence of the data to make sure those ones that need something potentially life-saving are the ones that get that highest priority response. Rick, any thoughts?
No, I typed a brief comment just to say that, it may have been that there might have been instances in there where maybe there should have been a PLSI performed and wasn't. I would guess that's a very small percentage, but I would suggest the vast majority of those were really reflective of the fact that, we really have a very small subset of calls that are truly that time-sensitive life and death sort of event that requires a life-saving intervention.
Correct. And we'll reach out to Dr. Jarvis. I don't see him on this webinar, but we'll reach out to him in writing and see if he wants to opine about that, and we'll get that out to the attendees. Dr. Miller, one for you as we go into our last minute. How do you balance evidence-based medicine on a national level with that of local medical oversight? And I think that this came from a California person because they've got local LEMSAs that might not be as nimble perhaps as the national evidence.
Yeah, great question. Certainly a challenging question as well. We are obviously lucky in the state of Texas that we get to make our individual systems, but I think really getting the stakeholder ownership and having some individuals to champion the new protocol changes along the way has been a great practice for us. But certainly, having the regional and the state level certainly complicates things, and I think the national organizations are also very cognizant of that, and they have implemented some things such as how to implement the evidence bases from the state level. And so pre-hospital emergency, or the pre-hospital guidelines consortium, and some of the others have some great resources on how to do that at both the local and the national level.
Thank you, Dr. Miller. Thanks everybody for attending. There is one more question that we're going to send to the Niagara folks. So check your email, not only for a recording of the link, but an answer to a very provocative question that we're going to ask them about this whole hot response thing. Thank you very much to our presenters, Dr. Miller, Dr. Monkley. Rick, you did a phenomenal job. Thank you to Amanda for coordinating everything. And thanks to the folks who attended. Watch for the link for the recording, and you can download the slides and the link that Amanda sent in the chat. So everybody have a great rest of your day, and please stay safe. Thanks all.
Thanks, everybody. Have a great day.